By the end of this training, participants will gain a comprehensive understanding of occupational diseases. They will be able to define what occupational diseases are, recognize their various types, and clearly differentiate them from other work-related illnesses. Participants will also learn about the main factors that lead to occupational diseases, explore effective prevention methods, and understand the legal and ethical responsibilities of both employers and employees in addressing these issues. Diseases observed in employees can be categorized into three main groups: general illnesses that are common within the wider population, illnesses that are related to the type or conditions of work, and occupational diseases that are directly caused by workplace exposures or activities. Work-related illnesses are conditions with multiple contributing factors where the working environment and methods play a significant role alongside other causes. For example, a heart attack may occur in an individual due to pre-existing genetic or lifestyle factors, but demanding working conditions can trigger or worsen it. While the main cause lies outside the workplace, certain risks at work can activate underlying health problems. If these workplace risks reach a high enough level, they can lead to the development of occupational diseases. Under Turkish legislation, an occupational disease refers to a temporary or permanent illness, injury, or physical/mental disability directly caused by the nature of the work or the conditions in which it is performed. The Social Insurances and General Health Insurance Law No. 5510 emphasizes that these conditions result from repeated exposure or harmful work practices, while the Occupational Health and Safety Law defines them more broadly as diseases arising from exposure to occupational risks. Most occupational diseases progress chronically, developing after prolonged exposure to harmful conditions at work. The relationship is so significant that the disease would not arise if the person had not worked in that particular job. For this reason, the definition of occupational disease includes both the nature of the profession and the duration of employment in the same workplace. Accurate diagnosis requires a clear demonstration of the connection between the illness and the employee's occupation. Article 63 of the Social Insurance Health Transactions Regulation outlines how occupational diseases are classified and the time frame within which they must appear after leaving the job to be recognized as work-related. This determination is based on the provisions of the regulation and its annexed occupational diseases list. In cases where clinical and laboratory evidence confirms the illness and workplace inspections verify the harmful exposure, the disease can still be officially recognized as an occupational disease with the approval of the Social Insurance High Health Council, even if the standard liability period stated in the list has passed. The liability period refers to the longest permissible time gap between the end of exposure to a harmful occupational factor and the manifestation of the disease. For example, asbestos-related illnesses can emerge up to 40 years later, while noise-induced hearing loss may develop within 6 months after exposure ends. The exposure period is the minimum time needed for symptoms to appear after harmful occupational exposure begins. For instance, noise levels above 80 decibels may require at least 2 years of exposure, while levels exceeding 85 decibels can cause damage in as little as 30 days. Occupational diseases have well-defined characteristics. They present with a specific clinical pattern, and their causative agents are identifiable, often detectable in biological samples. These conditions can be replicated in experimental settings and occur at higher rates among individuals in certain professions. Crucially, there is a clear causal link between workplace conditions and the illness. With appropriate technical and medical measures implemented at the workplace, most occupational diseases can be effectively prevented. The diagnosis of an occupational disease is based on 3 key principles: thorough clinical evaluation of symptoms, comprehensive laboratory testing to confirm findings, and most importantly, establishing a clear connection between the disease and the individual's occupation. Clinical evaluation begins with a detailed review of the individual's entire work history, identifying all potential exposures in the workplace. The timing of symptoms is examined to determine if they correlate with work activities. It is also important to check whether other workers in the same environment have similar complaints and to assess non-occupational factors that could contribute to the condition. Laboratory evaluation involves the use of radiological imaging techniques, biochemical analyses, and pathological examinations to confirm the presence, extent, and nature of the suspected occupational disease. These methods provide objective evidence to support clinical findings. For an illness to be formally recognized as an occupational disease, a confirmed clinical diagnosis must be accompanied by clear evidence linking the condition to the individual's job or work environment. Without establishing this occupational connection, the disease cannot be classified as work-related under official definitions. Establishing the connection between a disease and the occupation requires comprehensive workplace environment assessments and personal exposure measurements. These evaluations help confirm whether harmful factors present in the work setting are responsible for the employee's condition. According to the Social Insurance Health Transactions Regulation, occupational diseases are categorized into 5 main groups. A group includes conditions caused by exposure to harmful chemical substances. B group covers skin diseases directly related to workplace exposures. C group consists of pneumoconioses and other respiratory diseases resulting from inhaling hazardous dusts or particles. D group includes infectious diseases contracted through occupational activities. E group addresses illnesses caused by physical factors such as noise, vibration, or extreme temperatures. Group A covers occupational diseases arising from exposure to various chemical agents. These include 25 main categories and more than 50 subcategories of illnesses caused by chemicals such as metals, gases, solvents, acids, alkalis, and pesticides. For example, benzene exposure is linked to leukemia. Trichloroethylene can cause sudden cardiac arrest and nerve degeneration. Petroleum products are associated with skin cancers. Carbon tetrachloride exposure may lead to cirrhosis and kidney failure. Certain alcohols can result in blindness. Glycols have been linked to personality disorders. Group B covers a range of occupational skin diseases, from skin cancers and precancerous lesions to various non-cancerous skin disorders. Examples include contact dermatitis, either allergic or irritant, acneiform eruptions, pigmentary disorders, photosensitivity reactions, and contact urticaria. High-risk occupations include hairdressers, chefs, galvanizing workers, metal plastic industry employees, machine operators, paint industry staff, and printing press workers, all of whom are regularly exposed to skin-harming agents. Group C includes pneumoconioses and other respiratory system diseases caused by occupational exposure. These range from acute inhalation injuries like toxic pneumonitis to airway diseases such as asthma, chronic obstructive pulmonary disease (COPD), and chronic bronchitis. Parenchymal diseases can be organic, e.g., hypersensitivity pneumonitis, byssinosis, or inorganic various forms of pneumoconiosis. Pneumoconiosis occurs when dust accumulates in the lungs, triggering damaging tissue reactions, as seen in asbestosis, silicosis, siderosis, and berylliosis. Occupational exposures can also lead to malignancies, including lung cancer and mesothelioma. Other examples include respiratory illnesses caused by aluminum, hard metal dust, or allergens leading to occupational asthma. Group D covers infectious diseases acquired in the workplace through exposure to bacteria, viruses, fungi, or parasites. These include zoonotic diseases like anthrax and brucellosis, as well as infections such as tuberculosis, viral hepatitis, HIV, and meningitis, particularly among healthcare workers. Occupations at higher risk include animal breeders, farmers, veterinarians, butchers, healthcare professionals, and even hairdressers due to their potential contact with infectious agents. Group E covers occupational diseases linked to physical workplace hazards. These include excessive noise above 85 decibels, vibration-related injuries like white finger disease, and issues caused by extreme temperatures, poor lighting, or exposure to ionizing X-ray, gamma, and non-ionizing radio, microwave, laser, infrared, UV radiation. Pressure changes, whether high or low, can also trigger health problems. Industries at risk include construction, manufacturing, mining, shipyards, quarries, textiles, and the healthcare sector. Common outcomes range from radiation-induced illnesses and cataracts to noise-induced hearing loss, vibration-related joint damage, and injuries caused by repetitive strain or prolonged local pressure. The International Labor Organization ILO classifies occupational diseases into three main categories: diseases caused by agents, including physical, chemical, and biological hazards; diseases affecting specific organs and systems, such as the respiratory system, skin, and musculoskeletal system; occupational cancers, malignancies directly linked to workplace exposures. When classified by causative agent, occupational diseases fall into four categories: chemical-related illnesses resulting from exposure to harmful substances such as solvents, metals, or gases; physical-related conditions caused by noise, vibration, radiation, extreme temperatures, or pressure changes; biological-related diseases from exposure to bacteria, viruses, fungi, or parasites; psychosocial-related disorders linked to workplace stress, harassment, or adverse organizational environments. Chemical-related occupational diseases arise from exposure to heavy metals, aromatic and aliphatic compounds, and various gases. The risk is influenced by the concentration and toxicity of the substance, the duration and intensity of exposure, and the route by which it enters the body. Individual factors such as sensitivity, age, and gender also play a role. Over time, these exposures can lead to serious, permanent health conditions in employees. Chemicals can enter the body through three main routes: inhalation via the lungs, absorption through the skin, and ingestion through the mouth. Once inside, they may produce local effects at the point of contact or systemic effects affecting the entire body. Without proper protective measures, exposure to chemical substances can lead to serious health problems, including eczema, asthma, allergic reactions, various cancers, nervous system damage, and liver or kidney disorders. Direct contact may also cause severe burns or corrosive effects on the skin. Among chemical-related occupational diseases, poisoning is the most frequently encountered. Industrial poisonings usually develop slowly over time, meaning early exposure often goes unnoticed. Symptoms tend to appear only in the advanced stages of the illness, by which time the damage may be severe, and in some cases, even fatal. Physical-related occupational diseases arise from workplace conditions such as excessive noise or vibration, dust exposure, extreme heat or cold, and pressure variations both high and low. Exposure to ionizing radiation, e.g., X-rays, gamma rays, and non-ionizing radiation, e.g., microwaves, lasers, UV light also poses significant health risks in many industrial sectors. Noise refers to unwanted sounds that negatively affect human health and well-being. As a form of energy, sound can propagate through solids, liquids, and gases. Sudden exposure to extremely loud sounds with high sound pressure levels can damage the eardrum and inner ear. After leaving a noisy environment, individuals may notice a temporary hearing loss, which varies according to the intensity, duration, and nature of the noise they were exposed to. In cases of temporary hearing loss, normal hearing usually returns after leaving the noisy environment, with recovery time depending on the intensity and duration of exposure. However, long-term exposure to high noise levels can cause irreversible damage, meaning that hearing problems persist even after the noise source is eliminated, leading to permanent hearing loss. Noise not only disrupts communication in workplaces, but also prevents workers from hearing critical machine signals and warnings, significantly increasing accident risk. Prolonged exposure in noisy environments can lead to physiological changes such as elevated heart rate, increased blood pressure, altered breathing, and disruption of hormone regulation. The nervous and circulatory systems may be impaired, while heightened fatigue and stress contribute to greater irritability and reduced workplace well-being. For an 8-hour working day, the maximum acceptable noise level is 85 decibels. Exposure to noise levels above 70 decibels can trigger physical, psychological, and cognitive reactions and, over time, may lead to progressive hearing loss. Prolonged exposure to loud noise can cause irreversible damage to the hair cells within the cochlea inner ear, leading to noise-induced hearing loss. Once these sensory cells are destroyed, they do not regenerate, making prevention essential. When using earplugs, always start with clean hands. Hold your ear from behind with the opposite hand, gently pull it upward, and insert the plug with a slight twist for a proper seal. Testing the fit. In a noisy area, cup your palms firmly over your ears, then release them. If the noise level remains unchanged, the plugs are fitted correctly. When removing earplugs, twist gently rather than pulling them out abruptly, as sudden removal can damage the eardrum. During industrial activities like grinding, crushing, blasting, shaking, or drilling, significant amounts of dust are released into the air. Without adequate control measures, ventilation, PPE, dust suppression, prolonged exposure can lead to serious health problems, including eczema, asthma, allergic reactions, and even cancers. Biological origin occupational diseases can be classified into 3 groups. Bacterial illnesses caused by exposure to harmful bacteria in the workplace. Viral diseases resulting from contact with infectious viruses. Biotechnology-related health issues arising from the use or handling of biotechnological materials, organisms, or processes. Biological origin occupational diseases are most frequently observed in healthcare personnel and in workers involved in agriculture and animal husbandry. These illnesses are caused by microorganisms, and some can affect both humans and animals. Well-known examples include tuberculosis, anthrax, brucellosis, and various parasitic infections, all of which pose significant risks to workers in these fields. Psychosocial-related occupational diseases arise from workplace stress and its impact on both mental and physical health. Prolonged stress can lead to psychological disorders like depression and panic attacks, as well as psychosomatic conditions including coronary heart disease, peptic ulcers, colon disorders, hypertension, and even stress-induced skin problems. These conditions highlight the critical importance of managing mental well-being in the workplace. Poor ergonomic practices in the workplace can lead to a variety of health issues, including musculoskeletal disorders affecting muscles, joints, tendons, and bones. Workers may also suffer traumas or develop varicose veins from long periods of standing. In office environments, extended computer use can result in eye strain, back and neck pain, and carpal tunnel syndrome, all of which can significantly reduce productivity and quality of life. Poor ergonomics can lead to a wide range of musculoskeletal disorders. Shoulder and neck problems such as loss of neck curvature, tendon inflammation, cervical disc herniation, nerve compression, and joint degeneration. Arm, hand, and finger conditions including hand-arm vibration syndrome, tendon and nerve injuries, carpal tunnel syndrome, and circulation issues. Lower back, hip, and leg disorders such as chronic back pain, lumbar disc herniation, sciatica, foot drop, and joint degeneration. These conditions often develop gradually due to repetitive strain, poor posture, and inadequate workplace design. In ergonomics-related occupational diseases, the two primary contributing factors are repetitive movements, performing the same motion repeatedly over time, and cumulative trauma, where small, repeated stresses gradually cause significant injury to muscles, joints, or nerves. Musculoskeletal disorders from poor ergonomics progress through three clinical stages. Early stage pain and fatigue occur only during work and resolve with rest, with no effect on job performance. Intermediate stage pain persists even after rest, may disturb sleep, and significantly reduces work performance. Advanced stage pain and fatigue begin at the start of work, last through the night, and cause a marked drop in efficiency, especially in repetitive tasks. In ergonomics-related occupational diseases, low back pain is the most frequently seen problem. It usually develops due to the cumulative impact of repetitive, forceful, and incorrect movements rather than one sudden injury. With preventive measures and correct body mechanics, most cases can be avoided. While the majority of acute episodes heal, once the pain becomes chronic, treatment becomes significantly more challenging. When handling loads over 25 kilograms, always use appropriate lifting or transport equipment rather than relying solely on physical strength. For manual lifting, maintain an upright posture. Keep the load close to your body and take frequent rest breaks to reduce strain and prevent injury. The prevention of occupational diseases involves three main strategies: medical measures, regular health checkups, early diagnosis, and vaccination programs where applicable. Workplace environment measures, improving ventilation, reducing noise and dust, using protective barriers, and ensuring safe machinery and equipment. Employee-focused measures, proper training, correct use of personal protective equipment (PPE), and adopting safe working practices. Together, these measures minimize risk, protect worker health, and improve workplace safety. Medical preventive measures focus on protecting worker health through regular medical oversight and education. These include pre-employment health screenings to ensure job suitability, periodic checkups to monitor ongoing health, early examinations for at-risk workers, return to work assessments after illness or injury, and exit medicals upon leaving employment. Additionally, employee training on health risks and preventive practices is a key component of medical protection in the workplace. Employees play an active role in workplace safety by reporting hazards immediately to the employer or designated employee representative. They should cooperate in correcting deficiencies and addressing any violations of safety regulations. Within their own area of responsibility, workers must work together with the employer and safety representatives to maintain and improve occupational health and safety standards. Protecting employee health is essential for workplace productivity and safety. Failure to do so results in greater workforce losses, a rise in disabilities, more illnesses, and ultimately an increase in work-related fatalities. Maintaining strong occupational health and safety measures is therefore not only a legal obligation, but also a moral and economic necessity. Occupational diseases are directly caused by workplace exposures or conditions such as lead poisoning, pneumoconiosis, noise-induced hearing loss, and other illnesses linked to chemical, physical, or ergonomic factors. Work-related diseases, on the other hand, have multiple causes, with workplace conditions being a contributing factor, but not the sole cause. For example, neck pain, coronary heart disease, COPD, lumbar disc herniation, and chronic bronchitis. The diagnosis, treatment, and prevention of occupational diseases in Turkey are guided primarily by the Occupational Health and Safety Law No. 6331 and its associated regulations, the Social Insurances and General Health Insurance Law No. 5510 also provides a legal basis for defining and managing these diseases. Key supporting regulations include Workplace Physician and Occupational Safety Specialist Regulation, Chemical Safety Regulation, Noise Control Regulation, Biological Agents Regulation, PPE Usage Regulation, Dust Exposure Regulation, Working at Heights Regulation. These frameworks ensure a comprehensive approach to occupational disease management, addressing hazards from chemical, physical, biological, and ergonomic sources.